Well, good morning, everyone. Happy St. Patrick's Day to all of you. I see a lot of green out there. Yeah, good Irish Catholic down here? No? I'm so happy to welcome you this morning. I think we're getting a little bit of a late start. Maybe some people got an early start to St. Patrick's Day. But it's a beautiful morning, and we're happy to have you here with us at our 2018 Regional Breast Cancer Issues Conference. This is our 20th anniversary of hosting this conference here in Oregon, and we're very happy about that. And how about a round of applause for that? It's wonderful to see so many of you here with us today and throughout the state of Oregon. We have 6 simulcast sites that are joining us right now. We have our friends in Bend at St. Charles Cancer Center. We have folks down in Corvallis at the Samaritan Pastega Regional Cancer Center. Our friends out down the river in Hood River in the Columbia River Gorge at the Providence Hood River Memorial Hospital. And we have friends out in Newport at the Samaritan Pacific Communities Hospital, as well as Roseburg at the Community Cancer Center. And down in the Rogue Valley, we have our friends in Medford at the Providence Medford Medical Center. So greetings to all of you Oregonians across the state and our Washingtonians that are here in this room, as well as possibly out in Hood River with us for this conference. Today we're accompanied by healthcare providers in the breast cancer community. We're here with survivors and fighters and their loved ones. We're here with others who are advocates and supporters of our breast cancer community and on this journey together. For each of us, this is an important day to acknowledge, to learn, to support and feel empowered as we fight breast cancer together. The purpose of this conference is twofold. First is to provide each of you with the most current science-based information on risk reduction, treatment options, and quality of life. But today really is also a time for fellowship, to gather as a community, to offer each other the space of encouragement, a dialogue of finding strength and hope with each other. We are all here together to go through this with each other, for each other, and to know that we're not alone in this journey. As you can imagine, doing a conference like this is a considerable undertaking, to say mildly, and it would not be possible without the financial and in-kind support of the community and our sponsors. So I want to extend a gratitude for a few minutes here to those who had made this possible. I want to thank Odinate Therapeutics, our presenting sponsor. I'm going to share a few more words with them about them at lunch. But I also want to thank our supporting sponsors who are so important to this event. Moda Health, Providence Cancer Institute, Compass Oncology, Genentech, Kaiser Permanente, the OHSU Knight Cancer Institute, Sisters Network of Oregon and Southwest Washington, and Ethan Allen. And not to forget our media sponsors, iHeartMedia, especially K103, Coin 6, KUNP, LeGrand, and the Oregonian. So if you wouldn't mind giving me a round of applause to our sponsors. Before I introduce our wonderful keynote speaker, I just have to take care of a few housekeeping items. Restrooms are to the right of the ballroom. I trust that our simulcast sites know where their restrooms are. As a courtesy to our presenters and to all of our participants alike, please do silence your cell phones or turn them off so that we don't have that disruption, or put them on vibrate so that you can take calls that you need to take outside the room. At 11:20 in the Washington room, we're going to be hosting a meetup for individuals living with metastatic breast cancer. This will be led by 2 social workers, and the discussion will focus on finding strength and hope together. More information is on the first page of your packet. There's a conference schedule and map for the location of the breakout sessions in your conference folder. There's also boards just outside this room to help guide you. All of the sessions, except for the ones in this room, will be taking place in the business center. So you just walk towards east, I guess that's east, and you head past the grill and you'll see the rooms labeled back in there. We will also have volunteers stationed at different places, so when you see them and if you get lost, just go ahead and ask them where you need to be. Please note that this room also will be for lunch, so you'll come back here during the lunch hour. We really appreciate you choosing your breakout sessions ahead of time when you registered so that we could assign rooms accordingly. So please plan to get to your desired room on time. We do have limited seating, So once seats are taken, to follow fire regulation and in respect to the DoubleTree as well, we're not allowed to have people bring chairs into the room or to sit on the floor. So if that is the case, then you will need to choose another session. But thank you again for choosing ahead of time and helping us with following the fire code. For any attendee requesting continuing education, you should have checked in at the CE tables just outside these double doors in the lobby to pick up your specific forms. So if you haven't done so already, be sure to do that here this morning in between your sessions. You'll be given instructions for your discipline, and at the end of the day, this is where you'll return your evaluations and obtain your certificate of completion. And for imaging technologists, remember to sign in or out of each session. Your certificates will be mailed to you after the conference, and we really thank you also for your participation. During the session breaks, we welcome you to meet with our community resource exhibitors and enter their raffle. So you have raffle tickets that you got with registration, and you can go ahead and, when you visit with our exhibitors, which I hope you do, they have raffle packages, and you can put your raffle in there. And we will be putting on the screen at the end of the day who won those raffles. So you need to be present to win. That's the catch. We also have an opportunity just down the hall here to tell your story. And if you so choose, please do stop by and tell your story, and we will have photos taken as well as a photo booth, photo wall just outside the back of this room. One more thing, I would hope that you would talk with our local researchers. We encourage you to, about their current work, and the research poster sessions are there in the back of the room on the blackboard, so take some time to visit with them and to ask questions and learn. Now, let's start with the program. It's my honor to introduce our keynote speaker for this morning's session, and that is Dr. Katie Dunham, a breast cancer oncologist, surgeon at Compass Oncology. Dr. Dunham completed her medical degree at Royal College of Surgeons in Dublin, Ireland. Very appropriate today. She later completed her residency and fellowship at Baylor University Medical Center, and today Dr. Dunham will discuss the roles that bias and belief play in shaping our decisions, specifically how the emotional impacts of cancer diagnosis affect how we make surgical decisions and what different approaches we can take to improve communication and reasoning when making future decisions. So please join me in a warm welcome for Dr. Dunham.
Thank you so much. That was such a nice, warm welcome, and it's so nice to see everybody up and awake on a Saturday morning, even when it's pretty gross outside today. But I know it'll keep you inside, so that helps me out. So why is it that we're at a breast cancer issues conference and we're talking about psychology? And we'll talk about how over the years we have developed and progressed so much when it comes to the science of tumor biology and treating this disease. But there are so many other factors that go into what helps us to make our decisions. And at the end of the day, we realize that we usually have choices. And these choices don't really have that much of a medical difference, but impact us so much physically. The way that we see ourselves, the way that we perceive other people seeing ourselves, and can dramatically affect our quality of life. So in order to help patients and help ourselves make better decisions, it would help to know where our decision-making process comes from and understand what biases might affect these decisions. So first and foremost, happy St. Patrick's Day. As has been said, I did spend my formidable years in my 20s in medical school in Ireland, and I can tell you that I am part Irish, Irish American. There's 35 million Americans that are Irish, and there's only 4 million people that live in Ireland. So it's pretty impressive what we do over here in America. And for hundreds and hundreds of years, every single person who was in Ireland was Irish. Once the EU came in and Ireland started having a little bit better economy, more people started to move in. But for so many years, every single person who they looked at were Irish. So When you go over there, people aren't quite as exuberant about professing that they are Irish because they all know that they are indeed Irish. They might be kissing each other, but it's not because of that. So I did live in Dublin, and Dublin is remarkable in that it's very similar to Portland. The city is about the same size. It has about 500,000 people living within the confines of Dublin City. And like Portland, Dublin is split in half with a river. The river is the River Liffey. And also like Portland, people don't like to cross the river. It's not quite that wide. There's a lot of footbridges, as you can see. But if you were to go to the north and the south side of the city, people actually have different accents. When I was in my OBGYN rotation and I was on labor and delivery, there was a baby that was born, and anytime a baby's born, the pediatric resident would come and evaluate them. And this pediatric resident looks at this baby and said, I think there might be something wrong with this child. And so he gets his supervising resident come in. He's like, yeah, there might be something wrong. So they went and got the consultant, which is the highest level doctor that's in pediatrics. And he came in, he's like, I've seen one of these before. He's like, this baby is in fact Italian. And what we find is that we only know what we have seen before. We can only understand what we know, and all of these Irish doctors had only seen Irish babies, and all of a sudden having people from Europe, they looked a little different. And this is called a bias. Now, bias is essential for humans to survive. It developed when we were in our caveman era, when we're hunting for food, fighting off predators, trying to find a mate. We need to make snap decisions, think quickly, and hopefully stay alive, have babies, move on. For anyone who thinks that you don't have a bias, that in and of itself is a bias. And that is called a bias blind spot. It's where you say, oh, I can see all these other people, how they have a bias, but I really don't have one myself. And don't worry, we all do this. Everyone is guilty of a bias blind spot. So when we are making decisions, there's a certain type of bias that can really affect those decisions. And that type of bias is called a cognitive bias. And we're going to go through a couple of those types of biases that might impact how we may make decisions when we're confronted with surgical decision-making, medical decision-making within healthcare. So what is one of the reasons why these kind of natural, instinctual, emergency-like survival mechanisms happens in every day-to-day life? Why would we have a reactionary sort of impulse to make a decision? And the reason is because there is so much information available, and we are unable to process the amount of information that we have coming at us. And even, I would say today more than ever, just with the amount of digital information that is out there, this is even more prevalent. The first bias I'm going to talk about is called availability bias. And this is when we hear something, we really think about the very first thing that comes to mind. So this particular gentleman is afraid of dying of Ebola. His chance of dying of Ebola is quite low. And obviously there's a number of other things he should be more concerned about, but probably more likely during the time that there was an Ebola crisis, this was what was on the news all the time, so it's the first thing that came to mind. In the setting of healthcare, this might be more prevalent if you're to come in for a new consult and have something similar to what a relative had before, and you live through that, and their experience would be the first thing that comes to mind. Or talking to someone else, like, oh, this is what they had, this is what they went through, thinking that that's what you're going to go through as well. The next bias is called a confirmation bias, and this is where we know something to be true or we believe something to be true, and anything that confirms that belief just strengthens it, and anything that is contrary to that belief, we kind of ignore. In this gentleman's case, he's surrounded by information around him that the Earth is round, but he found some information that it's flat, and so he has even more strength in that belief. This next bias is called loss aversion. It's described more in terms of financial gain and loss, but basically it's saying that if I was to walk down the street and lose $5, it would make me twice as mad as if I were to walk down the street and the happiness level that I would get from finding $5. And it's a little bit more of an extrapolated idea in medicine. But if you were to think about having a treatment plan in front of you and all of the losses that we might have when we have that treatment plan. In cancer, it might be the loss of work for an amount of time, of being able to take kids to school, the loss of hair, the loss of energy, the hassles of having to go to and from an office, and how powerful that might be in helping make our decisions compared to the gains that we might have from the treatment. So present bias, not like a present I'm going to give you, but present like the here and now, is basically saying that things that are more closely to today that might be a reward are going to be more preferred over something in the future, even if the future reward is greater. So if I was to say to every one of you, would you rather have me give you $1 today or $3 tomorrow? A fair number of people would take the $1 today. But if I said, would you rather have $1 in a year or $3 in a year and a day, everyone would take the $3. Even though they're both 1 day apart, the future is a little bit different that we look at than the here and now. So when it comes to rewards or gratification that we might have closer to right now, we might pick those decisions. If we have a vacation coming up, it might get in the way of our surgery scheduling. Something like that might just be stronger to us because it's a reward in the present. So framing effect. This is just where you take the exact same information, frame it in two different ways, and the more positive information is something that we're going to take more strongly or adhere more to. So if you have two types of frozen yogurt, one's 80% fat-free and one's 20% fat, everyone's going to buy the 80% fat-free frozen yogurt. If I tell you that you have an 80% chance of survival or a 20% chance of mortality, you're going to say, well, I want the 80% chance of survival, even though it's the exact same thing. Anchoring effect is a little bit, this is used a lot in negotiation, where basically the very first point of information that we have is what we take to frame everything that we use. So for example, if somebody was told they have 3 weeks to live, and they get online and say, oh, I found this grapefruit diet, I'm going to try it, and they eat only grapefruit for 4 weeks, and all of a sudden they pass that 3-week time period, they're like, grapefruit, cure me. So it's just that first bit of information that we use that we construct the rest of our thinking. So how does our brain work? We make decisions based on information that is present in our environment and present in our memory. And some of these things can be faulty, and some of these things can be very powerful. So our senses, our reasons, we make about 35,000 decisions a day. Most of them we don't think about too hard. We wake up, we're like, do I sleep in? Do I get up and go for a run? Do I take the freeway? Do I take side streets? Do I go and get coffee? Or do I just power through and have some water? All of these decisions are made pretty quickly and we don't think too much about them. And we use different cues from our environment to help make these decisions. One of the most important parts of our brain for helping make these decisions is called the prefrontal cortex. And this is larger in humans than any other mammal. It takes up residence in our brain from about our eyeballs back to our ears. And it's pretty much the control center for making all of these decisions. We have our senses that send information up through our brainstem and go to that part of our brain, and then they send information back down for us to act on our decisions. An older part of our brain is called the limbic system, and this is mediated all of those survival instincts that we had when we were cavemen for foraging food and fighting off predators. This is controlled by the amygdala. And the amygdala is not very rational. It is more emotional and impulsive and moody. And when we work within our limbic system, we usually make a lot of decisions that we regret later. The oldest part of our brain is the brainstem, and this doesn't really involve a lot of conscious thought. It's more autonomic processing. So breathing, our heart beating, our reflexes like coughing and sneezing. It's super important, but it's not going to be part of our decision-making process. So when we're alert, when we're safe, when all of our stress hormones are at moderate levels and everything is in homeostasis in our bodies, then this prefrontal cortex is firing on all cylinders. It is upregulated, and it's keeping everything in control. And the amount of biases that are going to go into decision making are going to be at their lowest. When we're stressed and we have an increase in stress hormones in our body, the amygdala takes over, and the signals that are going from our prefrontal cortex are weakened. So then that's when we start having more of the emotional impulsive reactions for our decision making. And we know that when people are diagnosed with cancer and when they are being treated for cancer, that their psychological distress, their anxiety and depression levels skyrocket. In the first year from the time of diagnosis and treatment, 50% of women score high on a distress scoring system, mostly anxiety, but we just know that those stress levels increase. So it's important to recognize that that is going to be a baseline factor that we're going to be using some of our more primitive parts of our brain when we're in that sort of elevated level of stress. Additionally, we have chronic stress that can change the way that our bodies function. When we have chronic stress, we have stress hormones that are continually being released in higher levels in our body, and this increases our chance for having chronic medical problems like high blood pressure, diabetes, obesity. It also weakens our immune system and increases our chance for developing infections. We know that in this increased chronic stress level that it increases the availability for tumors to grow in our bodies. And we also know that people who score high on a hopelessness and helplessness score, meaning that they are at the highest level of dealing with chronic stress and feel like there's nothing left, that they do worse from their breast cancer. So I have a couple patients who have very much struggled with decision making, and they were gracious enough to let me share their story, their personal stories, with how they came to their decisions and how they felt about them today. The first patient is a 55-year-old female. She had a history of left breast cancer 6 years prior to her presentation. She was treated with a lumpectomy, and this was followed with radiation, and she took tamoxifen for 5 years. At 6 years, she had her regular screening mammogram, and a 5mm mass was found on the opposite breast. As you can see here, this is her mammogram, and there's this little tiny itty-bitty area that no one would be able to see if it wasn't circled by the radiologist. But she's got pretty large breasts, and she would be a good candidate for breast conservation. But she was feeling very guilty about her decision, like she caused this because she should have had a bilateral mastectomy when she first had her cancer. That's how she felt. And so she was struggling with what her decision should be. So why is it that we have the option between a small surgery, lumpectomy, where we just go around the mass and take out the tumor, and a mastectomy, which is a large surgery where we take out the whole breast and sometimes reconstruct with a new implant. Why is it that we have these two vastly different surgical procedures for the same disease? And I can tell you it wasn't always like that. In fact, not too long ago, there was no choice at all. So breast cancer is as old as human history. 5,000 years ago in hieroglyphs in Egypt, it was recorded that people had breast cancer. Granted, there was no treatment for that. Hippocrates in about 400 BC speculated that there are 4 humors in the body, and those humors need to be in balance. It's phlegm, blood, yellow bile, and black bile. In order for us to be healthy and safe, we need to have all of those humors in balance. There was a philosopher named Galen in the 200 AD who felt like we needed to do something to balance these out, and that's where the advent of bloodletting came in. And it continued on to about the 1700s. Bloodletting was performed by barbers in the medieval era, and that was actually the beginning of surgeons. So that's where my specialty came in. So the excess of black bile, or melancholic, was thought to be the cause of cancer. And once we became a little bit more aware in the 17th and 18th centuries that black bile does not exist, then this theory started to go away. And there were a number of people who developed a lymphatic or limp theory of cancer. They felt that cancer may start from the lymph nodes with either a coagulation problem, and the idea of taking out lymph nodes was thought to possibly be curative. So taking some of these theories and the advent of the 20th century where we had aseptic techniques and anesthesia, it was a perfect time for surgical development to occur. And at that period of time, there was a gentleman named William Halsted who really took a keen interest in breast cancer. This guy was very smart. He is pretty much the reason why we have residency today for all doctors. And he really took all of these theories to heart and developed a surgery called the Radical Mastectomy. Now, this took the breast tissue, the lymph nodes under the arms, and the muscle that's behind the breast, the pectoral muscle, all out on block or in one large specimen, because he thought that what happened is that we had tumors that started and that they grew out, and that if we could get around that growth, that it could be cured. And he did this on 50 women, and after 5 years, he published his data in 1894 that 40% of those women he called cured, so they had no evidence of disease. And this was remarkable, because up until this period of time, we had nothing. So this became the standard of care. This became adopted across the world, and it continued for about the next 80 years. Now, during that period of time, it's not like anything was not developed. There was a lot of other stuff going on, but we just did not switch over to a different mindset until the 1970s. During the 1900s, X-rays had been discovered, and they were found to not only be diagnostic but therapeutic. There was one gentleman named Solomon who took mastectomy specimens. He took 3,000 of them and x-rayed them and was able to identify tumor characteristics and patterns that we see on mammograms. Mammography was developed in about the 1950s, and it's still our standard of care for screening today. Radiation was also found to shrink tumors. Now, it wasn't fully understood when we first started discovering the availability to shrink tumors, and a lot of the early pioneers ended up developing cancers as a result of radiation from their early work. Chemotherapy, the thought behind it pretty much started in around the period of World War I, when mustard gas was used. And it was discovered that these soldiers had very low white counts. So it was thought maybe to be a possible way of treating leukemia. Obviously, we did not treat leukemia with mustard gas, but just the idea that maybe chemicals could be used to treat cancer. And over time, this was developed in the early 1970s. The first breast cancer chemotherapy regimen was developed by the Milan group in Italy. So in the 1970s, we had a huge liberation movement. There was Vietnam, there was women's liberation. That coincided with scientific discovery, and it pretty much has changed the way that we treat breast cancer. Some women weren't too excited about going in and having a radical mastectomy. At that point in time, it's not like people would have a diagnosis, think about it, and go to surgery. They'd have a breast mass, go in under anesthesia, have that mass biopsied, have it sent to pathology for a frozen while they're still asleep, and if it was positive, they'd have a radical mastectomy and wake up. So some people said, hey, I really don't want to do that, and one of those people was this lovely lady, Babette Rosamond, and she was an author, and she had read that maybe this huge surgery wasn't necessary. So she said, I am not going to consent to having this radical mastectomy. I only want you to do the biopsy. And then she found the gentleman in the middle. His name is Barney Krill. His father founded the Cleveland Clinic, and he worked there. And he was a large component of choice, surgical choice, having alternatives. And so he was starting to do less surgery with what is now considered to be a lumpectomy. The problem was that he didn't have a lot of evidence for performing the surgery. So in came Bernard Fisher. He's a surgeon, and he really did want to bring data to surgery. He brought evidence-based medicine, randomized controlled trials to surgery and surgical development. He chaired the National Adjuvant Bowel and Breast Project, and he was able to show first, that a simple mastectomy, not taking that muscle below, and had the same survival as a radical mastectomy. He was further able to show that people who had a lumpectomy or less breast tissue had the same survival as people who had a simple mastectomy. We did find that people who only had the lumpectomy ended up having higher rates of local recurrence. So then he proceeded on with another study that showed that people who had a lumpectomy and radiation had about the same local recurrence rate as people who had a mastectomy. So this was a huge paradigm shift. And this did not come easy, because all of these surgeons had all known this Halsted method for 80 years. And we have already talked about the confirmation bias. So we look for things to confirm what we already believe, and things that go against that we ignore, because change is tough, and change is really tough when you're a surgeon. So this was really hard to adapt, but once there was very strong data, things started to change. And part of the reason things started to change were because, one, this patronizing era of medicine was over. I had to look up who this guy was. I had never seen this show, but I've heard the Marcus Welby era of medicine, and so this was ending. One of the reasons for that was advocacy groups like the Susan G. Komen Foundation. This was founded in 1982 by Nancy Brinkler in honor of her sister, really because she wanted women to have education and empowerment and able to develop better breast cancer choices. And this worked. People started to know more about breast cancer. People started to know more about screening. And women became more involved in their surgical decision-making, this shared decision-making opportunity. So we went from a paternalistic way of medicine to more shared decision-making way of medicine. So here's your information, here are your options, what goes with your own personal choices and values, and let's come to a decision together. the problem is that we had such good data that has developed so long ago that now we've almost come full circle. And there was such a strive for patients to be able to have choice. And we have data to back up that choice. And we see that people have done so well with these lumpectomies and radiation that now there are a lot of people who are saying, I don't think that women should have that choice anymore. We should just do the lumpectomy and radiation. And part of the reason for that is that there's a rise in the amount of people who are having bilateral mastectomies. One reason that it's felt that this is too much or an epidemic is because of the cost. So it costs more to do bilateral mastectomy and reconstruction, either with a implant that's tissue-based or one that is silicone or saline-based, than it is to do a mastectomy alone or breast conservation. Now, Medicare data, they're about the same, but in this particular paper, they were adding in complication costs because the complications are higher if you have a larger surgery. So there has been a giant shift in first understanding that there is availability of having less surgery, and the number of people who have started having mastectomies, bilateral mastectomies with reconstruction has gone up. Now, about 65% of people who have the opportunity to have either a lumpectomy or mastectomy choose lumpectomy still. So the number of people having lumpectomies really hasn't changed so much. It's just that the number of people who are choosing bilateral mastectomies over unilateral mastectomies is going up. And one of the reasons for that was in 1998, there was a healthcare act that was passed by Congress that said most insurance companies have to pay for reconstruction if a woman has a mastectomy for breast cancer. And one of my patients that kind of went through this decision-making process of trying to figure out if she wanted to have a unilateral or bilateral mastectomy was a 48-year-old lady. She had a right axillary mass about 2 years before she presented. She had a mammogram at that time, and it didn't show anything, so she didn't think anything of it, but it started bothering her again. So she went and got a workup. It was biopsied and found to be cancer. This is what her breast looked like. This is what we call extremely dense breasts. It's very hard to see through this mammogram. You can't even see the mass on this even 2 years later. When we do closer imaging, or what we call magnification views, you can kind of see a little bit of a white area in there, and that's likely her mass. So she had an ultrasound and a biopsy. In order to try and tell if there was more going on, since we couldn't see through this breast, we did an MRI. And she has a lot going on. So that was the main mass. This is another little area that lit up. There's another one, and there's another one. And she was very interested in breast conservation. She really wanted to have a lumpectomy if possible. So we started biopsying these areas. And unfortunately, one area was positive, and the other area they didn't get what they were looking for. So it was decided that she ought to have a mastectomy, and she was trying to figure out if she should have both sides. She had a strong history of breast cancer, so she underwent genetic testing, and she really then thought very strongly about, does she want to have a unilateral mastectomy or bilateral mastectomy, especially if she doesn't have information that helps to improve that decision for her. So what is the advantage and disadvantage of having one versus both? There are way more disadvantages than advantages from a medical point of view. One, there's a longer surgery and increased complication rates. You don't take away the risk of breast cancer in total by taking out the breast tissue, because you can't take out every single little cell. It does go down by about 94%, but people still have about a 3 to 5% chance of breast cancer even after mastectomy. There's no survival benefit from doing a mastectomy on the non-affected side. And we do know that one breast cancer does not spread to the other side and vice versa. The reasons why people decide to get a contralateral mastectomy could be because they have increased risk, either from a genetic mutation or increased family history, or they're very young. Symmetry. Having one side reconstructed and look very different than the other side could very much change your view of yourself. And even if the risk reduction isn't as high as we'd hope, there still is a risk reduction from having that contralateral mastectomy. In addition, there is a high amount of anxiety that goes with mammograms. And so every single year going in and having another mammogram and having that burden of anxiety between the mammogram and the diagnosis or the outcome can be a huge burden and something that people might want to avoid. So what about women that don't have breast cancer at all? These are typically women that are high risk and found to have a genetic mutation that might make them want to have a prophylactic bilateral mastectomy. This is called the Angelina effect. Angelina Jolie had a BRCA1 mutation and elected to undergo a bilateral prophylactic mastectomy, and then later bilateral oophorectomy, or having her ovaries out, because she also had increased risk of developing ovarian cancer. My third patient had the same mutation. Her sister was diagnosed with breast cancer, found to have a BRCA mutation, so she was tested and also found to have that mutation. She elected to have her ovaries removed because she also had that increased risk of ovarian cancer and wanted to have a bilateral prophylactic mastectomy as well. So BRCA mutations were discovered when epidemiologists saw that there were certain families that just had a high amount of women with breast cancer. So they looked at their genes, they looked at their DNA and found where this mutation was off. And we know that people with a BRCA mutation have an estimated lifetime risk of about 40 to 85% for having breast cancer. And bilateral prophylactic mastectomies reduce that risk to about 3 to 5%, so it's pretty remarkable, the difference. Just taking out the ovaries for the increased risk of ovarian cancer reduces the risk for breast cancer by about 50%. So we also have information about the theoretical gain, the theoretical number of years gained by undergoing these procedures. So we know that the earlier, the younger women do these procedures, the more theoretical years of life they gain. So if a 30-year-old who has a BRCA1 mutation undergoes a bilateral mastectomy, she gains theoretically 3 to 5 years of life by having that procedure. Most people who have prophylactic mastectomies elect to have reconstruction. So this usually involves taking out the breast and leaving a skin envelope, a lot of times with the nipple if possible, and placing an implant. Usually it's a deflated implant that's slowly inflated over time and then exchanged at a later date with either a implant that's made of saline or silicone or one that's made of tissue from the body. And there are risks that go with this procedure. Risks are higher for patients that have comorbidities or so either underlying medical problems, especially obesity, high blood pressure, diabetes, people who smoke, and people who are older. The risks that are associated with this surgery are infection and bleeding, wound complications. They can lose those implants, have to have a whole nother number of surgeries later to help them to gain back the reconstructive look that they were going for. So the first patient that had the new breast cancer on her other side elected to have bilateral mastectomies with reconstruction. Because she had radiation before, she had what's called a latissimus dorsi flap that was placed over her right implant, and her other breast was removed and she had an implant placed there as well. She's very happy with her decision. She did have a prolonged recovery just for pain control, but no other complications. And she's currently volunteering and involved in advocacy. This is a picture of how that lat flap is done using tissue and muscle from her back and flipping it over around to the front. The second patient When I say she had a lot of deliberation, she had a lot of deliberation. She asked every single person that she saw. She went to support groups. On the day of her surgery, she asked every nurse that came in, the anesthesiologist, what they would do, because she couldn't not decide if she wanted one side or both. Ultimately, she decided to have a unilateral mastectomy. She unfortunately had a number of lymph nodes that were involved, and so she underwent chemotherapy and radiation, and she's looking forward to an implant exchange later this year. When I talked to her about how she felt at that time and looking back, she feels that that was the one thing she had control over, and that's why she made it such a big deal. But looking back, it really wasn't as big of a deal as she made it seem in her mind. And that last patient, she had a bilateral mastectomy. She did not have any high risk factors for increasing her risk of complications, but she did have complications. She had wound complications, and she lost one of her implants and has had a number of surgeries since then. And I asked her what she would want me to tell you or discuss with you about her experience. And I asked her if she regretted her decision, and she said she does not regret her decision, but that there's no way to actually know really what you're going through. You can read or think and feel like you're doing all the research in the world, but it's really hard to know what you're going through. And that having an oophorectomy in your 30s and going immediately into menopause and feeling like an old person is way worse than you could ever imagine. And that if you're going to make this decision and go through this huge process, you should take a look at who's in your life, who your partner is, who your social network is, and make sure it's strong. Because if you're in a relationship with somebody and it's not a strong relationship, it's not going to go well. It's only going to fracture that more. So the physical aspects are not the worst part of it. It's the emotional aspects that have really been the most difficult thing to deal with. So none of us know what's going to happen in the future, and looking back on the past, we all know what the best answer would be. This is called hindsight bias, and none of us have this liberty of knowing what's going to happen, so we can only take the information that we have available to make the best decision we can. We have a whole team of physicians and a whole team of providers that are involved in care. In addition to all of the people in the medical field, we have advocates and we have family members, and all of these people are so important in helping patients to make better decisions, to make more thorough decisions, and to think about what we're going through. And part of the way to reduce bias and to make these better decisions is to recognize these things can happen and try and minimize them. One is identifying availability bias. When a patient has a new experience, as physicians, we can ask them about their prior experiences to help frame. They may have had a mother that had breast cancer and had a horrible experience, and they don't want to go through any of that, or it freaks them out. And maybe asking about those experiences and seeing what they went through, discussing, acknowledging, and talking about the differences maybe between now and then. The differences in our advancements, in medical and our treatment options, and maybe there might be different types of cancers. So just trying to reduce that availability bias and not making somebody think that this thing is going to happen to them. We can reduce anchoring bias. We can ask people what their expectations are. If somebody perceives their risk to be very high, and you tell them, hey, your risk is 30%, they're going to think that that's the very high number and want it to be below that. So if somebody comes in who does not have cancer and they have a family history, and you ask them, what do you think your risk of developing cancer is? And they say 80%. You're like, well, you know what? Actually, it's 30%. That seems like a win. So just being able to identify how people's minds work and to help them to really understand what those numbers mean. And numbers are hard, and we give a lot of them in medicine. And anytime we give them, it's very important to spend time to explain what they are. Providing written material is probably one of the most important things that can happen. When we have a new consultation, people retain less than 80% of what we say. We all think we're charming and amazing and fascinating, but they're only listening to 20% of what we say. So providing written material or having another person to be present with us so that they can be a witness or a scribe and be a sounding board later, so that they can kind of say, no, that's not what happened, or what do you think about this experience? Mindfulness techniques. When we have such a high level of stress and so many emotions going into something and we feel like we have to make a decision so quickly, which is not true, that decision does not need to be made right then and there. Taking time, feeling the water underneath your hands when you're washing them, or just seeing colors, or getting your mind away from this overwhelming thought, this impending doom, can help to just take a breath and really make more rational decisions. One of the things that we have in our arsenal that's being developed are these decision aids or decision tools. They're becoming more and more prevalent on the internet, and something that will probably be involving more in the future. And these basically are about hour-long, specific, patient-specific, kind of choose-your-own-adventure type PowerPoints that we can have. And it tells patients very slowly and specifically what their diagnosis is, what it means, what their choices are, and what the risks associated with those choices are. And we found that if patients can go through this information before an appointment or after an appointment, it can really help to solidify that information that they had and make them feel more confident with their decisions. We haven't found that it really makes them change their decisions, but just more understanding and confidence behind those decisions. For anyone who wants to know more about the history of cancer, The Emperor of All Maladies is a great book. It is also available as a documentary on PBS done by Ken Burns. It's fantastic. And for information on the art of choosing or how to make better decisions, this is a great book as well. I would like to thank all of you for listening to me. I would like to thank my whole family and my Compass family for being here as well. And most of all, I'd really like to thank my patients, because I love my job and it's such an honor and to be here. And I really just appreciate the trust that they put in me. So, any questions?
We love you.
No? We're good? Oh, yeah? No, 20%. They retain 20%. They lose 80. Yeah.
The patients who undergo the hysterectomy,
Mm-hmm.
and they're young, put them on hormones, because there's some great studies that show.
Oh, yeah. So when somebody no longer has their uterus, they can go on estrogen. And there's actually a lot of, yeah. When they lose their ovaries and their uterus. So if they have their uterus still, you can't put them on estrogen only. It usually has to be with progesterone. But if they have their ovaries and their uterus taken out, they can be put on estrogen only. And estrogen alone actually potentially might have protective benefits for breast cancer. So that is something that could be an option, especially for women that are going through menopause quite early and are having a lot of traumatic effects from that. Yes? I'm a breast cancer surgeon.
So you actually do the surgery and then you do the presentation on oncology?
For medical oncology, no. So I do surgery. I mean, I tell them about them in general, but I do not make those decisions with them. That's the medical oncologist. Yeah. Oh, sorry. Her question was, what do I do? Any other questions? Yeah. You can, in certain circumstances, yes. If the tumor is not close to the nipple, we usually do a biopsy in order to ensure that there's not tumor underneath the nipple, but in certain circumstances, if somebody's body habitus allows for it, then yes, we can do nipple-sparing mastectomies. No, because it's really just, sorry, she asked, won't we have to still do mammograms if we leave the nipple? No, because we take that tissue out beneath the nipple, so it's really just nipple skin that is left over, just like the rest of the skin. There have been a lot of studies that have looked at the safety of nipple-sparing mastectomies, and the chance of developing a breast cancer in the future is not significantly different than for patients who have aerial or just skin-sparing mastectomies. Yeah. Mm-hmm. Okay, so her question was for the patient that had her original cancer in her left breast that underwent a lumpectomy, and she had a cancer then 6 years later in her other breast. She's asking if that was a metastasis or if that's a new cancer, and it's a new cancer. So when we have it develop a cancer in the contralateral breast, it's considered to be a second or a separate cancer. Yes?
You mentioned mindfulness. Mm-hmm.
Mm-hmm.
I wonder how more positive psychology principles could be infused into the process of the patient to help reduce that stress level.
I think it's very important. I think that probably a lot of the psychologic interventions that could be underdone would be easy and should have a lot more attention, because I think it makes a bigger difference than we really give a lot of attention to. We do know that people are happier if they feel like they have more control. And we know that it's really important. I mean, we don't do all of this. We don't do all of these huge surgeries and all of this chemotherapy and radiation so that people are miserable. That's not why we do it. We want you to go back and have a good and healthy and normal life. So I think that we do need to incorporate more of that from the get-go if we can. Yes. Yes. Mm-hmm. 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 Okay, so her question was, when a patient has a diagnosis, there's an urgency to having treatment started, but there's also the importance of having time to reflect and make a good decision. So how do we balance those two ideas out, and how do we explain to patients how urgent treatment is? And we know, based on looking back at all of the data that's available, that we want to start treatment within 30 days of diagnosis. Sometimes it feels like it's too much time, and sometimes it feels like it's not enough time. So there does need to be a balance, and we only have so much control about when we see a patient for the first time. The way that we have mediated that is we try to get a patient, if they are surgical, into surgery within 4 weeks of seeing us. If they have something, other type of treatment up front, usually it's started a little bit quicker. But that's our goal. So there are certain ways to try and give somebody more time to think while not delaying their surgery. And one of those things we can do is genetic testing if they qualify for it, so that they can have time to think while the genetic testing is pending. Seeing other consultants or second opinions can help give them time to think. And letting them know, hey, you don't need to make a decision today. You need to make a decision probably in the next week or so. Take your time, think about that information. Some people think a week's not enough time. Some people think a week's an eternity. Everybody has a difference in what that time period is. I think being upfront and just saying, hey, this is our goal and this is how we're going to get to where we need to go. But it's not perfect. There's no perfect science. So that's kind of my best answer that I can give you for that. Yes?
When you do the testing of the breast cancer tissue, is there a proliferation study done on that at the same time to see how fast the cells proliferate?
Typically, yes. So when we don't do what we used to do in the 70s, where we put a patient under anesthesia and do the biopsy. It's now done with a core needle biopsy by the radiologist. So this little piece of tissue is then sent to the pathologist, where they diagnose it, and then it undergoes a number of studies. Some of them are receptors, like hormone receptors, or HER2 that we look at, and then part of it is grade. Grade just basically tells us how similar are those cells to normal breast cells, or how different are they. And then proliferation rate, like you were asking, that tells us how quickly the cells are growing, pretty much. So yeah, we get all that information usually up front on that biopsy. Yes?
In your slide of the risk-reward of unilateral or bilateral mastectomy, if you're lucky enough to have the choice of only having cancer in one breast, and you're faced with that decision, I would like to see the symmetry word taken off of the choice, because bilateral mastectomy does not necessarily guarantee symmetry.
No, it does not.
But that's we're not told.
Yeah, and I think that it's hard, and I think pictures. We try and give pictures, we try and show what other people have had done, but no matter what, taking off a breast and trying to reconstruct one is just not as good as what God gave you. And no matter how good our plastic surgeons are, they're just not going to be that good. So it's more often something that we find if somebody has they're just going to be very off balance, that the symmetry word comes into play. It's not to say that you're going to have a perfect new reconstructed breast, because that doesn't happen.
It's that psychology of seeing that word and as processing, putting it into our minds. And my other challenge is make sure plastic surgeons have 2 separate picture books. Reconstructive picture books and breast cancer picture books, because that's another psychology that we can think going in and base our decision on.
I think that's a good point. So what she's saying is that when you go into a plastic surgery office, you'll see all of these pictures, and a lot of them are cosmetic procedures, not necessarily done for cancer, and that those pictures start going in your mind, and you think more about the cosmetic outcomes being similar to those of the cosmetic patients, and that's not really reality. I think that's important to know.
I have a question. What determines whether you will have some kind of chemotherapy before surgery as opposed to after?
So a lot of different factors go into determining whether or not we have chemotherapy before or after surgery. One of them has to do with the size of the tumor. Another factor has to do with lymph node involvement. Another factor has to do with the actual tumor biology itself. So if somebody has a certain type of tumor biology, they may have chemotherapy before versus after. So those are the main reasons why we might do chemotherapy beforehand. Sometimes we'll do it for surgical reasons. If somebody wants to have a lumpectomy and their tumor is too large compared to their breast size to have one, we can reduce the size of that tumor by having chemotherapy up front and enable them to have that decision to have breast conservation surgery. Is this my last one? Okay, this is the last question for you.
Whole process that you've described, brachytherapy can be used to do a lot of saving of tissue and so forth. Do you have a place where you can recommend that to be done, or is that still a different kind of science?
Brachytherapy is done, and so brachytherapy is a partial breast irradiation. So it's one of the ways that instead of having the whole breast irradiated, that part of the breast is irradiated, and it's typically done after a lumpectomy. And so it can be an option depending on the size and the tumor characteristics. And I know that Dr. Ravi Chandra is going to be in one of the breakout sessions talking more extensively about radiation therapy after this, so you can maybe ask him to describe that in more detail for you. I don't know where is he sitting? He left. All right, so that's it for me. Thank you guys so much. I really appreciate it.
Thank you so much, Dr. Dunham, for sharing the psychology behind decision-making and how bias and the emotional impact of a diagnosis can affect those decisions. I'm very grateful to have you here today. So we will have a breakout now, or sorry, a break. We will be breaking in for about 15 minutes, 10 o'clock. Our first sessions will begin. Remember, the one session's in here. All other sessions are in the Business Center. And for those who are with us today with stage 4 metastatic breast cancer, the breakout session gathering will happen in the Washington room immediately after our first sessions. Thank you.